Hi, everyone. Welcome to another episode of our podcast, The Animal Heartbeat. My name is Jose Novo Matos, and I'm here with my partner in crime, Kieran Borgea. And we'll be talking today about prognostic factors in myxomatous mitral valve disease. As you know, mitral valve disease is the most prevalent heart disease in dogs, and determining disease severity and prognosis is paramount for vets and clients. To quantify disease severity is really important to decide when to intervene. And until recently, we were mainly dealing with medical treatment and when to start medical treatment. But recently, or in the past 10 years, maybe, surgical mitral valve repair became a very important option with two highly experienced centers in the UK offering surgical repair. Most recently, an hybrid transcatheter mitral valve repair procedure has been developed by the Colorado State Group, and you, Kieran, have been among some of the first ones doing this procedure. So what are your thoughts about the importance of quantifying disease severity?
I mean, it's incredibly important, isn't it? It's just so common. I think the figures from the Vet Compass group at the RVC a couple of years ago, looking at just left apical heart murmurs prevalence in primary care practice, estimated that mitral valve disease affects about 1 in 20 dogs, so 5% of dogs. But that was including all breeds and sizes and body weights. And actually, if you look at those smaller breed dogs, it's far more common than that, isn't it? And certain breeds, of course, the poor old Cavalier in the UK at least is the sort of poster child for mitral valve disease. And on necropsy evaluation of Cavalier valves at age 10, 100% of them had some degree of myxomatous change. Now, that doesn't mean, of course, that they've all got murmurs at age 10, but it just gives you an idea of how common it is in those older dogs. And I think, I commonly see it in dogs of 3, 4, particularly in Cavaliers. What's your youngest Cavalier, do you think, you've ever seen with meaningful myxomatous changes on the mitral valve?
The classic figures would be middle-aged to elderly dogs.
Yeah, it's true.
Those are the classic figures for myxomatous mitral valve disease or significant myxomatous mitral valve disease. So the disease as an age-dependent penetrance, if you want, or is more likely to develop as dogs get older. But I think I would say 5-6 years. And then what is very tricky and maybe beyond the scope of this episode, but maybe still interesting to touch on it, is when you have very soft murmurs or you do not have a heart murmur, and then on echo you find already some signs of valve disease.
It's a tough one, isn't it, to know what to do with that?
Yeah.
I mean, I think I tend to say just wait for a murmur. And treat it like any other dog. But it's difficult because there's a disease present even when they're very young. I did a bit of breed screening in Cavaliers a few years ago. I got sort of quite interested in it since my interest has waned a little in the breed screening side of things. But it was very interesting because I would commonly see dogs with some degree of mitral prolapse at even age 18 months or 2 years in the Cavaliers, which I was quite shocked by. But obviously some of those dogs will have some degree of mitral prolapse on echo, and they won't get a murmur till they're 7, 8, 9, 10. So it doesn't, echoing them that young, I don't think is important necessarily prognostically. I think for breeding, sure. And actually very important for breeding and probably more useful than echo in youth is something that is a really underestimated prognostic factor, I think, for mitral valve disease, which is family history. There's a lot of good data out there from, years ago now, 30, 40 years ago, showing that dogs whose parents had murmurs younger also had murmurs younger. So therefore, not only is the disease inherited in particular breeds of dog, a lot of research is in Cavaliers, of course, but it's not just Cavaliers. It's going to be the same genetic basis or a similar pool of genes that's causing it. But not only was the disease inherited, but actually the severity of disease, the age of onset was inherited. So if we have a dog whose parents were both dead by age 6 because of heart failure, even at age 1, I'm worried about that dog. I'm worried about the future for that individual. And I think that's a really important prognostic factor, perhaps one of the best we've got for long-term prognosis. Unfortunately, it requires family history. And most owners of pet dogs, Cavaliers, whatever, don't have that family history. They have something from the breeder saying, yeah, everything's fine. It's challenging, isn't it? I don't know what your experience is of these dogs, or of cats maybe as well, because that's a similar thing, isn't it?
Generally, we don't have a lot of family history. Yeah, this will be a tough disease again in terms of genetics, family history, inheritance, because it's clearly a polygenic disease.
Yeah.
So many environmental epigenetic factors are likely to play a role. But agreed, family history is an issue. But as you were saying, age of onset is important. This disease has a very, very long asymptomatic, subclinical, preclinical stage.
Yeah.
Which I think is useful for the clients to understand that dogs remain in stage B1 for many, many years. And so
60% of those dogs in B1 never develop signs of heart failure.
Exactly.
You know, all that Borgea work, which, you know, a lot of what we're going to be talking about today is based on Borgea's longitudinal studies. And that's fantastic stuff. That observational natural history of disease is super important, isn't it? This is where the philosophy that some vets have of, oh, if there's a heart murmur, I'll give it vetmedin or pimabendan because it's better to be safe. Well, oftentimes, if you do that, 60% of your treatment's unnecessary, isn't it? Exactly. And that's a challenge for me. I don't agree with that.
Yeah, absolutely. And exactly. And to communicate that to the client and to discuss that is really important. So that means that, okay, you detect a heart murmur. And then if you have the classic breed, small breed, medium breed size dog, middle-aged to elderly, left apical murmur, that means in the large majority of cases, mitral valve insufficiency caused by myxomatous mitral valve disease. So if the patient has no clinical signs, this will be a stage B dog. And then the big question is it B1 or B2? We need echo and or x-rays. What would be your comments on that? Would you echo, if a vet cannot do an echo, would you still rely on x-rays to define B2? Do you always want to have an echo? What's generally your approach?
I think radiographs are better than nothing. There's some of the work from Sonia Gordon's group at Texas A&M has shown that if you have what I would call quite significant cardiomegaly on a radiograph. So they were looking at two things. They were looking at vertebral heart scale, VHS, which has its own challenges in measuring. But they were looking at VHS of 11.5 or more being suggestive of stage B2 myxomatous mitral valve disease. And that seems reasonable to me. I would say that many of these dogs are not quite as big as that to be associated with stage B2. But echo is more sensitive, of course. So we're used to using echo and we'll pick up those earlier cases. The other thing that they were looking at was vertebral left atrial size, which, you know, if any of the listeners out there aren't familiar of it, we'll tweet a picture this week of how to measure vertebral left atrial size and VHS. But I quite like the VLAS because it's only one measurement, whereas the VHS is two, and therefore you have compound error affecting it. The vertebral left atrial size is reasonable. I mean, it's not perfect, but it's reasonable. And if the vertebral left atrial size was 3 or more, that was more suggestive of stage B2. So I think those are reasonable ways of looking for B2 on radiographs. And echo is always better, though. And you can learn to echo that, you know, that there are protocols for training people to echo, which, you know, are shown to work nicely for people to learn how to measure left atrial and left ventricular dimension. And actually in the consensus statement on mitral valve disease, the authors there talk about using a combination of echo and radiographs, which is what the EPIC criteria were. But actually, most of us don't bother using the radiographs. I think most of us would just rely on the echo because we know that the echo is sensitive enough to detect those earlier cases and doesn't require the sedation that maybe a radiograph does, although not always. I think that the problem with echo is that sometimes we find a dog where, you know, the left atrial size might meet the criteria for stage B2, but the left ventricular internal dimension doesn't.
Yeah, I wanted to ask you that. How do you approach those cases? If so let's just to remind everyone, so the EPIC criteria for stage B2 or LAO more than 1.6, and the left ventricular internal diameter, normalized left ventricular internal diameter 1.7 or bigger. And yeah, as Kieran is saying, many of us will see cases that one of the criteria is met, but not the other one. So what's your approach on those cases?
Do you know, I used to give them the benefit of the doubt, if you like, and I would say, this dog is B2, albeit early, and I would start pimavanserin treatment. But actually, I've changed my approach now through working with colleagues who've been more rigid on those criteria. And actually, I agree that the EPIC criteria, they weren't very conservative. So they may have detected some dogs who were at the very start of progression. Now, I'm not saying that doesn't mean we shouldn't use those criteria. I believe we should to decide to treat with pimavanserin or not. But there are certainly some cardiologists out there who really strongly disagree with the criteria and think they're too lax and that we're going to include lots of dogs who don't need treatment. I disagree with that. I think when we look at the EPIC data, we can see that whether the criteria are a little bit liberal or not, those dogs have a clinically significant benefit over time. So I would say that using those criteria from the mitral valve consensus statement is appropriate. It is what I do, but I do use the criteria. So now I am more strict with myself and my decision making, and I will use left atrial to aortic root ratio combined with left ventricular internal diameter in diastole normalized to body weight. So I use those two. In addition, if I've got a borderline case, I will also use the two-dimensional measurements of absolute maximum left atrial diameter in long axis and LVID in diastole in long axis from a 4-chamber view, and normalize them for body weight as per the Lance Visser paper from 2018. I think that's a great reference for echo values. Yep. And I use that a lot. If I've got borderline cases, I look at it and go, well, if Visser's criteria say that this is within reference, I'm not going to treat. If Visser's criteria say that it's over the reference interval and my LAAO or the LVIDDN is large, then I will treat. So I use the Visser criteria. Now, they weren't considered in the consensus statement, which is fair, I think, because the consensus statement was really aimed at non-cardiologists. It's aimed at interested vets who are performing echo, vets in primary care practice, to help them make good decisions about a large population of dogs. I don't think the consensus statement works for every single case, and I'm sure that you and I will use it as a vague guideline and we'll make our decisions based on other criteria as well, not just those one-dimensional measurements of a complex 3D structure.
Exactly. Yeah, that's a good thing, and that you mentioned that, and we'll discuss that maybe a bit later. Mm-hmm. Because how much shall we, or what's the danger to rely on just a one-dimension measurement? The guidelines are recommendations and will never be the Holy Bible.
Absolutely.
And that certainly has not been the aim of the authors. And so, as you're saying, they work as guides, as a guidance, and especially for vets with standard of care echo abilities, and also for specialists to use as guidance, and then you need to adapt to your case. So, but that's great. I agree. So I'm strict, let's say so, and I want both criteria to be met before starting. Let's say in this case, pimavanserin, especially because I don't think there's a huge urgency.
I agree with you. When they're on that borderline, they've got years, exactly. Right? Yeah, exactly. In most cases.
Exactly. And so that's great. But now this brings us to another point. If then we are doing echo, and most studies have shown that the best prognostic factors and are echo variables. And so, can you comment on that? Which factors do you look on echo that help you determining how bad is the disease? Or let's say if we are talking about subclinical, preclinical, as you prefer, disease, which factors, which echocardiographic factors you use to determine and assess what's the risk of these dogs to develop congestive heart failure or the overall outcome?
The real challenge is the preclinical dogs. The stage B dogs, or stage B, well, B1 and B2 actually are important to think about. Once they're in stage C, once they have clinical signs of congestive heart failure, well, their prognosis is poor. The median survival time is between 9 and 12 months, depending on the breed and other things. So I will use that figure to talk to owners about this. They've got an idea of the fact that the prognosis is poor long term, without sort of a major intervention, some sort of surgical intervention for those cases. And it is, of course, the minority of dogs who go for surgical intervention because access to surgical facilities is limited. In the UK, we're super lucky. We have 2 centres doing mitral valve repair on the pump, on the bypass machine. And we have another center doing transcatheter edge-to-edge repair. So we're very, very lucky to have access to those facilities. The problem is the cost. Surgical repair in the UK costs between 15 and 20,000. And the transcatheter edge-to-edge repair is actually around about 12,500, something like that. These are expensive procedures. I think because of that, we need to really think about this as a big population disease and think about what most dogs will receive, or what care most dogs will receive, which is medical therapy and monitoring. So going back to the echo is super important, obviously. And I think once we identify them as solidly in stage B2, so they've got a left atrium aortic root ratio of 1.8 and an LV IDDN of, I don't know, 1.9, 2. Okay, they have a worse prognosis. We know that their survival time is shorter because they have a bigger heart. There's a lot more nuance than that, though, because of the nature of these measurements. They're quite blunt tools, and what they're doing is they're looking at the secondary effects of the mitral regurgitation on the heart and RAS activation, etc., on the heart. They're not looking at the regurgitation itself. So in humans, they don't really look at heart size as a primary measure of mitral regurgitation severity. They will use MRI to quantify the mitral regurgitation severity. In many cases, or they'll do things like measure your left atrial pressure based on catheterizing the pulmonary arteries and measuring a wedge pressure. So obviously we could do that, but we'd need to anesthetize our patients. They can do it in conscious people. We need to anesthetize our patients for that, and that immediately makes that, A, expensive and challenging. B, it makes the pressures change. So in a conscious animal, the left atrial pressures will be very, very different to an anesthetized patient. So it's one of those sort of rules where actually trying to measure it for us makes it abnormal. So I think echo is what we are left with, and trying to estimate mitral regurgitation severity on echo is really, really hard. I've become much more interested in this in the last couple of years because we were working on this mitral surgery program, and because now we're in a situation where we have got other centers that we can refer to do these advanced procedures. So I like to be able to make an assessment of them and say to an owner, look, your dog maybe doesn't have the largest left atrium yet, but we need to be planning and thinking ahead because its regurgitation is very bad.
Let me just stop you there for a second.
Yeah.
Because you are bringing very, very interesting and important topics. So just to summarize, the ACVM guidelines define the disease staging based on one-dimensional measurements of chamber diameter, LAM, sure, left ventricular diameter. And as you were saying, these may not be sensitive enough to detect different severities of mitral regurgitation, because we are looking at the secondary effects of mitral regurgitation. Again, in the defense of these methods, they are easy to use. They are simple, efficient.
They're accessible, aren't they? A lot of people can do it.
So it makes a lot of sense that they were used in very large clinical trials.
Yeah, definitely.
EPIC, the Quest. So that makes a lot of sense. Protect one-dimensional measurements makes a lot of sense. But now, more recently, as you were saying, in humans, they quantify LA volumes, LV volumes, and they try to quantify, or they quantify regurgitant fraction. And in the past few years, there have been at least two very interesting papers, one from Dr. Oyam at the Pennsylvania group on quantifying mitral regurgitant fraction in subclinical disease, mitral valve disease, and now more recently from Lance Visser at Davis at the time. And so there are different ways to quantify regurgitant fraction, but the methods they suggest, the volumetric methods, are not that cumbersome.
No, I think the two main methods that are used are a method called PISA, or rather PISA-based methods of quantifying mitral regurgitation severity. So PISA is a proximal isovelocity surface area, and we need a really good color map on the valve. We need really nice settings on the machine. We need just great angulation, looking at the coalescence of that flow on the ventricular side of the mitral valve. And what happens is actually, before it sprays through the orifice in the mitral valve, the velocity is the same in a sort of hemisphere of flow. If anyone's brain is melting now thinking about that, well, fair. It took me a long time to get my head around this, but basically it's a phenomenon of physics. So that the blood sort of queues up to go through the hole, and as it queues up, the speed in that area is the same. And you can quantify that speed by looking at color maps. And basically you look at the area of the color map. So you measure the PISA, and that gives you an estimate of the orifice size in the mitral valve. And then, of course, from there, you need to do that and add some other measurements, some Doppler-based measurements, VTIs and mitral regurgitation and volumes and things. And actually, then you can come up with an estimate of mitral regurgitation severity. So you can estimate something called regurgitant fraction, which is how much blood is going backwards of the dog's stroke volume. So, if the regurgitant fraction is 50%, then 50% of blood from the left ventricle in systole is going back into the left atrium. 50% sounds like a lot, but a lot of dogs are much higher than that in advanced disease. The other way of estimating that.
When you start measuring and you realize that 50% of the total stroke volume is being pumped backwards.
Oh, it's mind-blowing.
Isn't it? It's like, it's huge. Because you look at the left atrium is big and so on, but when you start realizing how much blood is being regurgitated, it's crazy, isn't it?
No wonder the left atrium is huge.
Yeah.
The other method of doing it is to, since we're thinking about volume, just measure volume. So you can estimate forward stroke volume. You can, look at the stroke volume of the left ventricle using 2D planimetric methods, and you can look at transmitral flow and things and put that all together and use those without using the color maps to get an estimate of regurgitant fraction. Personally, I think the volumetric methods are probably more repeatable. Certainly in my hands, they're more repeatable. Well, in the past, when I've shown my residents how to measure PISA, they've just laughed at me and said, well, how do you know that's the right time? And I said, well, I don't, I just think it is. And if everyone thinks it is at different times in the cardiac cycle, then of course it's just a random number generator. It's very settings dependent. It's very angle dependent. PISA is a problem when there are two jets of mitral regurg, which is not infrequent, and you have to get the sort of just the right angle to catch that on your echo. Otherwise, you may miss secondary jets. You may get an abnormal shaped PISA. I think it was the group from Liverpool a few years ago published a paper on PISA where they were talking about it and looking at repeatability. But actually, one of the problems is that PISA can change throughout the cardiac cycle. So, of course, you have to look at maximum PISA. But who knows what that is? It's very challenging. It's very challenging.
Much of our prolapse may also affect PISA and the hemicircle and exactly change across the cardiac cycle. So incredibly challenging to do, and you have to play with the Nyquist limit and so on. As you were saying, it shouldn't work as well in eccentric jets, which is what defines the disease. And
especially in early disease, the jets are eccentric, and as they become, as the heart becomes dilated, you get more central looking mitral regurgitation jets. So PISA is better probably in more advanced disease, but that's not when you want it. You want it in the early disease. You want to spot the dogs that are going to dilate and are going to get secondary change. And that's so using PISA when it's at its most accurate is probably when it's at its least useful, I think.
Absolutely. And then I think that's exactly why I don't think it became a widespread use technique, because it was quite many years ago. So I think
they use it in humans.
Yeah, exactly. What I think is very exciting, as you were saying, are the volumetric methods, because in fact they do not require any new measurements, or are based on measurements that we all routinely do on echo. But having said that, as you were mentioning, there are two ways to quantify volumes. So the initial work from Pennsylvania just a few years ago calculate volumes using the prolapse ellipse method, where you basically cube the minor axis of the left ventricle. You determine the left ventricle diameter in systole and in diastole on M mode, and then you raise that value to the power of 3. And this is similar to what the Tycholk's method uses, if you want. And it has been shown that as the ventricle dilates and loses its normal ellipse shape, then these assumptions are lost. This way of determining volume will overestimate the volume, because the ventricle becomes more of a sphere and is not an ellipse anymore. Having said that, it makes sense that this group did these assessments using linear dimensions, because this is very easy and quick to acquire, and our measurements that people are already acquiring, so it makes a lot of sense. But then later on, the Visser group used the Simpson's methods. So you were saying you would generally use the modified Simpson method of discs.
Yeah, exactly. To use the volumetric. So I do a planimetric based method. It's a problem, isn't it? Because with all these studies, if one person gets good at it, their repeatability gets quite good. and their intra-observer variability gets quite low. It's when different centers are doing it, and they may have learned differently, they may have trained differently, they may have a different approach slightly, and therefore, of course, comparing results from one center to another is not necessarily very easy, but probably not that important in clinical practice. It's more important.
That's a very good point. That's a very good point. And people should stick to the method that they are more used to.
Right.
And then what makes their workflow better when they are scanning patients, which measurements they acquired. And again, the data from Dr. Oyama would use M mode linear dimensions, which we will already be acquiring them when assessing internal diameters. So it makes sense.
I'm not a fan of M mode though.
Yeah. In general, I totally agree. I would use M modes. I think the only time I use M mode is probably for mitral valve disease.
Yeah, I think so too.
The EPI criteria used M mode, and so then
right,
I would use M mode. But I agree. And then the Simpsons method, just to be fair, also the Simpsons method is of course not perfect and requires a very good image quality. One needs to be certain that we are not foreshortening the left ventricle. So long axis views, you need to be sure that you have the whole left ventricle. Sometimes you have an apical dropout, or the left ventricle is foreshortened. So this will of course underestimate the volumes. So you will also require very, very good image quality. But I think the bottom line is exactly what you were saying. People should stick and train with one method and then use them. And the methods are not interchangeable, but then if you stick with your method and calculate regurgitant fraction based on always with your method, that would be useful. What is interesting looking, and I have some figures here from Visser's data, which raise a lot of questions. So when they determine regurgitant fraction in B1 and B2 dogs, and so B1 and B2 were defined based on the ACVIM criteria. The regurgitant fraction in stage B1 ranged from 9 to 58%, and in B2 from 14 to 76.
Right.
That's the range. And these, of course, would tell us that some dogs that were B1 could already had severe regurg, and some dogs were classified as stage B2, the regurgitant fraction was not that severe.
Yeah.
And so, yeah.
You see, I think that's a temporal phenomenon. So that's obviously a cross-sectional study. So it's looking at, one point in time. Imagine you have a dog whose mitral regurgitation is not that severe, but it's had it for a decade. Well, it might have had prolonged RAS activation, prolonged increase in aldosterone, fibrosis of the heart, remodeling. So you might have not very severe MR, but a large heart, which would classify the dog as stage B2. But in B1, you might have fairly acute MR, a rupture of a minor chordae, quite bad mitral regurgitation, but the heart hasn't had time to stretch yet. So I think we can explain that from time and just the nature of the sort of heterogeneous nature of the population here that we're talking about. So I would sort of argue that what we need really to assess these different methods of looking at mitral regurgitation severity is longitudinal prospective follow-up studies. I mean, we're going to say that about everything in cardiology, aren't we? We're going to say it about feline heart disease. We're going to say it about interventional cardiology. We need follow-up in the same patients, not just looking at different patients at different stages of disease. That's not enough to understand the natural history of the diseases, really.
Agreed. And it is, again, as you were saying, it's a very important point. These are early days, and both studies were cross-sectional, and certainly these groups are working in longitudinal data. What is very interesting to speculate is how this could affect your intervention timing, how these affect when you start treatment.
Right.
And if we have longitudinal data that then will show that we will define B1 and B2 differently based on regurgitant fraction, or based on having a more holistic approach. Because of course it's naive if we just use LAEO and left ventricular internal diameter to define a 3D structure. So now we start having a more holistic approach where we add at least regurgitant fraction. How would that work if we combine these variable? How would that help you defining outcome, prognosis, and when to start treatment?
Yeah, I agree. I think we're in sort of an exciting time for mitral valve disease. If you'd asked me 5 years ago, I wouldn't think I'd be saying that. 5 years ago, I probably couldn't have cared less about the future of mitral valve disease. I said, well, there are some centers doing some surgery. We've got some pimabendan now. That's great. What are you worried about? It's easy to define stage B2. But you're absolutely right that there's more and more things on the horizon where, more minimally invasive methods potentially down the line of performing a minimally invasive annuloplasty. Maybe they do that in humans. Thinking about the number of centers doing bypass repair across the world, it is increasing. There's definitely, more people thinking about TEER, the TEER procedure. A friend of mine has just performed the first one this week, in fact, in Brazil. In Sao Paulo, so that's starting there. It's Claudio Busadori, as you know, is doing it in Milan. We were doing it in Bristol last year, and now a team in Birmingham are doing it in the UK, and more and more centers across the US. I mean, I don't know how many now, I've lost track. The big question with that is, what's the optimal time to intervene? And I don't know. My suspicion is the best time to intervene in those dogs with a transcatheter procedure is the day they go into heart failure. But that's unrealistic. And ideally, just a little bit before that, 2 weeks before they go into heart failure. So this is where the early assessment of regurgitant fraction is vitally important, because I don't think all dogs in stage B2 will benefit from the TEER. And some dogs in stage B2 are probably too advanced. Open heart surgery on bypass, they can do a lot more with the valve than you can with a TEER, and therefore they can deal with patients from very early to very late disease very successfully. But with the TEER procedure, there's a small window of opportunity, and this is why getting good at assessing mitral regurgitation severity, I think, will be really important. I think, Jose, now that we've talked a bit about assessing regurgitant fraction and what that might mean for dogs and for repeatability and decision making, we should probably split this episode of the podcast, because there's a lot to talk about with preclinical mitral valve disease and the prognostic factors. So I think if we wrap up this episode now and just tease that in the next episode, we're going to be focusing on better established prognostic indicators on echo for looking at dogs with mitral valve disease and deciding about monitoring and treatment of those dogs, rather than thinking about these more complex measurements of regurgitant fraction. So join us next time on The Animal Heartbeat. Don't forget to follow us on Twitter and on Instagram, both of which are at heartbeat_pod. Please contribute, please ask us questions, and be part of the community of listeners who are interested in veterinary cardiology. Thanks very much for listening. Welcome to our newest episode of The Animal Heartbeats, hosted by myself, Kieran, a veterinary cardiology specialist, and my fellow veterinary cardiologist and podcaster, Jose Novo Matos. We're talking on this occasion about mitral valve disease, focused on the prognostic indicators for dogs with mitral valve disease. In the last episode, we talked about assessing regurgitant fraction and how this may play a role in decision-making for surgical candidates. At the moment, we don't have the perfect way of assessing regurgitant fraction, and we discussed the pitfalls of echo assessment of regurgitant fraction last time. In this episode, Jose and I will be focusing on how to assess these dogs in the earlier stages of disease and how those assessments may influence our decision-making surrounding treatment, monitoring, and management of these dogs. And to that end, we're going to pick up where we left off last time, thinking about assessing mitral regurgitation severity in dogs with degenerative valve disease. Let's just take it a step back and think now more about the medical treatment, because this is what people are going to be doing, isn't it? And we're interested and excited about these other procedures, but actually treating medically is fundamental to these dogs as a population worldwide. And we're saying that, maybe LAAO can be challenging. Do we say that every dog in stage B1 should be seen once every 12 months? Which is what the consensus statement says. Maybe there are things we can spot that make us a little more concerned about that patient, or maybe a stage B2 dog who's come in and is in stage B2, but they need some anesthesia or fluid therapy. What's our short-term risk assessment? What do you use in those scenarios? We've talked about the linear measurements and the volumetric assessment, I guess, of MR. So we've gone from the very basic assessment to the very advanced assessment, which is super challenging. Is there anything in the middle that you use?
Exactly. So mitral inflow is an important way to assess, to assess left atrial pressure. When we measure, for example, mitral inflow with myxomatous mitral valve disease and severe mitral regurgitation, the peak velocity does not necessarily mean LA pressure. It may just reflect volume overload. But mitral inflow is an important variable to measure. And that's been shown repeatedly in many studies. And the delay study, I think the delay study was a great study also to assess echocardiographic variables and predictors for congestive heart failure. Exactly. And they showed that E velocity more than 1 meter per second, I believe, LAO more than 2.1, and left ventricular diameter normalized to body weight more than 1.9 were independent predictors of congestive heart failure. So mitral inflow is something I lose a lot of time where is like our default measurement, well, overall in echo, but the case you were mentioning, then if I have a borderline left atrial size or left internal diameter, I like to assess mitral inflow and peak E velocity.
Yeah,
to assess left atrial pressure or filling pressures, if you want, or risk of congestive heart failure. Do you ever measure vena contracta?
It's a great question. I used to work with a cardiologist called Julia Sargent who did a lot of work on the vena contracta. She converted me to vena contracta and said, "Oh, this is a great measurement." And the whole time she was doing this, the research, which is a great study, and that shows the prognostic value of mitral inflow as well, of Emax, as well as all of the stuff that's from the Borgea group as well. But in Julia's paper, they actually were looking at comparing echo measurements with the gold standard of MRI. This is the paper I'm talking about. She published a few in this area. But they're looking at the gold standard of MRI, which is great. This is the holy grail, isn't it? What can we do on echo that compares well to a gold standard? Vena contracta was something that, where I was working at the time, we loved this as a measurement, the idea that looking at vena contracta normalized for body size. So they normalized it for aortic diameter, like left atrium is normalized for aortic diameter. And basically, the bigger the vena contracta, so the wider the neck of the jet of mitral regurgitation, the bigger the hole, and the worse the regurgitant fraction on MRI. And that's true. It corresponded very, very well with the MRI-derived regurgitant fraction. Another method, which I think we all hate as cardiologists, is something called jet area ratio, or JAR. So the jet area ratio, people often refer to it as dial-a-jet, because it's so affected by the color settings and the 2D settings on your machine that you can make quite bad regurgitation look quite small, and quite small regurgitation look much larger than it really is. So, if you're going to use comparing the size of the jet or the area of the jet to the area of the left atrium, which is how to perform that measurement, or if you're just going to assess it subjectively and go, wow, that's a big jet, you need to get your settings right and repeatably the same across different patients. We all thought that, in this research that Julia was doing, the jet area ratio would perform really poorly. Actually, it performed quite well too, which was a bit sad. Because that's not what we wanted to see. But Julia's settings were very repeatable, and she got very good at it. So actually, the message there is probably get your settings right, and look at it. Now, for all that I've said that I like the idea of vena contracta and how well it performs, do I measure it routinely? No. Yeah. It's an additional measurement that I don't think brings anything to me, because I'm really happy with the mitral inflow. But maybe there are people out there who aren't so happy with their Doppler measurements or don't have access to pulse wave Doppler potentially on their machine, but maybe they've got color. In which case, you could probably measure a vena contracta.
Yeah, the same. I generally do not measure it. I like to have a subjective assessment of it. I like to look at it.
I like to get the pictures for it, right?
Exactly. Yeah. No, just exactly. Looking at it and see, as you were saying, I also like to have a subjective assessment of how big is the mitral regurg in proportion with the LA size, without measuring the area, and then look at the vena contracta. Of course, the vena contracta, as any other measurement, to have problems, depends on orifice geometry, may also change across the cardiac cycle and so on. But I like to have an idea of subjective idea, or is especially in case where again equivocal cases. But I would generally do not make decisions on that. So to summarize, LAO, left ventricular diameter, mitral inflow, LV fractional shortening. I bring that because there was, the group from Dr. Dominic, Oriol Dominic in Novara, they described these MINE score. So MINE score stands for mitral insufficiency echocardiographic score. This is a severity score. Very good idea, great idea. They picked standard echocardiographic measurements that everyone is doing, and they combined them to create a score. and they use LV fractional shortening. So what's your opinion on that? Do you ever look at LV fractional shortening to determine severity of the disease, or not really?
Oh, so I mean, if you've got mitral regurgitation, you've got a lot of blood coming into the ventricle from the atrium in diastole. And then obviously the stroke volume is artificially increased because there's blood going backwards into a low pressure chamber of the left atrium during systole. So the fractional shortening should be hyperdynamic in these dogs. The problem is, as the disease advances and it gets worse, the fractional shortening will reduce because the function will deteriorate. And eventually the fractional shortening may normalize or become subnormal. So the problem with fractional shortening is if you look at it by itself, you don't know what it means. You can't measure function in these dogs. And I think actually, measuring fractional shortening, measuring function with fractional shortening is pretty poor anyway. Do I do it? Is it part of the picture? Yeah, sure. In DCM and systolic dysfunction. But with any dog that's got significant mitral regurgitation, whether it's a bad DCM or a PDA or anything, using those two-dimensional functional estimates is terrible. It's just thrown completely out. And especially with mitral valve disease, when it gets bad, as I say, it sort of is a bell-shaped curve where the fractional shortening increases early in disease and then drops late in disease. I don't know how useful it is. I guess if I see a dog with huge left atrial size and huge left ventricular size and the fractional shortening is normal, well, that's bad because it means the function is very low. But if the fractional shortening is hyperdynamic, so 50, 60, 70, well, I would expect that. And I don't know what that means. And I don't know what it should be if the function's normal. So it doesn't really help me. I see why it's included in the score, but I don't know that paper very well, I have to say. And I'd be very interested to know how they dealt with that bell-shaped situation. Are they just looking at dogs in stage B1, B2? Because if they are, then probably the larger the fractional shortening measurement or the greater the fractional shortening measurement, the worse the mitral regurgitation fraction. Do you ever use it?
When Tommaso, the first author, great guy, doing a lot of
he's doing some great work, isn't he?
Yeah, great work. And when they first describe it, we start using it, and we ask the residents to start reporting it. Because what I like sometimes when we have these new papers is to gain experience with those new methods. So then
try it, and if you don't like it, don't use it.
That you can have a good opinion about it.
Absolutely.
So we start writing the mind score on our reports and so on, and then whenever we see the dog back, we will compare the mind scores and so on. And nice. I think my only issue with the mind score is that if I don't think I would have included LV fractional shortening,
right?
And I think that the score makes it as the more hyperdynamic the LV is, the highest the score. So the more
sure. And that makes sense, doesn't it, for early disease?
Exactly. But then, as you were saying, the problem is when there is that plateau and so on. But I think most importantly, as you were saying before, it's a great idea. And we have, I think, well, I'm sorry that I bring cats to every episode, even though there's nothing.
We should play like the animal heartbeat bingo. So, or a drinking game or something. So people listening should, when Jose mentions feline cardiomyopathy, take a drink, Yeah,
exactly. You'll be drunk very soon. It's just because we need something like that in cats. Instead of just say LV wall thickness, more than 6 millimeters.
Oh, yeah.
Cut off, the holy grail, or 5.5, whatever, to have a score, to have combined measurements. So as they did with mitral valve disease. So I like these scores because I think they make sense. But I agree. I think I generally do not look at LV fractional shortening, and maybe I would like to see this data without LV fractional shortening, but I believe the group is collecting data now for like longitudinal data,
like a validation. I think any of these sort of new kind of methods of looking at echo, it's important when you're researching to do a derivation cohort and a validation cohort, because you might derive them from a population of dogs and it looks great, and then you validate it in a different population of dogs, and because the population is different, well, maybe it doesn't. Well, it won't perform as well. That's just the nature of it. It won't perform as well. And there was a nice paper a few years ago now. God, I can't remember what it's called. But they were looking at using NT-proBNP and some other things to look at severity of mitral regurgitation and progression of disease. And they used a scoring system. And in one paper, they did derivation validation, and the derivation cohort had an accuracy of, I think, 85% or something, which is pretty good. And then in the derivation cohort, it was more like 70. Sorry, in the validation cohort, it was more like 70. So of course, it's always going to drop when you apply it to different populations. Just to play devil's advocate about these scoring systems, whether it's the MIND score or something, looking at other disease. With the MIND score, we're looking at things like Emax, left atrial size, left ventricular internal diameter. I would argue they're all interrelated, because obviously you have worse mitral regurgitation severity that drives all of those things.
Yeah.
So surely these scores are going to change exponentially.
Yeah.
It's not like it's going to be a straight line on a graph with increasing score and worsening regurgitation fraction. It's going to be an exponential curve. So as the mitral regurg gets worse, the score is going to amplify and amplify and amplify. So there must be a point at which suddenly it's a tipping point and the score suddenly increases. How do we deal with that? Because it means that probably they're not going to be very sensitive to change. They're going to suddenly change. And that's my problem with it. The other thing is that statistically, of course, that they're not really independent predictors, or not all independent predictors. They're going to be very related to each other.
Exactly. So multicollinearity. So that's why we need multivariable analysis and a model that we are sure that the factors that try to predict the outcome are independent. Totally agree. And thinking about the delay study, they showed that. So in their final model, they exclude left ventricular diameter because that variable was highly correlated to LA size, as you were saying. It's complete sense. So in their final model, they had LAO, Emax, and NT-proBNP, which I want to ask you in a second about it. But so that's incredibly important, that when we define a score, that we avoid factors that are measuring the same thing. Because they increase or decrease. One is related to the other. So mitral valve inflow, peak E velocity, LAO, clearly are independent factors.
That they are different things.
Many studies. And so I think those are certainly very, very good, two very good variables. So in each of our episodes, we discuss biomarkers. And this, of course, is important because...
And so far, we haven't really used them, right?
True, but we always talk about them. Well, of course, you work as a cardiologist in a referral center. So it's a different population and approach to cases. But do you think there is any place to measure NT-proBNP in a primary care setting?
I'm going to reference the work of a former colleague and friend of mine, Melanie Hazel, whose PhD was looking at mitral valve disease in a longitudinal population of dogs. And she produced some very nice work, some of which was looking at fibrosis, looking at spironolactone. But actually, one of the big papers that jumps out for me is looking at NT-proBNP and troponin and cardiac death. In terms of prognostic factors, you can't really argue with an endpoint of cardiac death, can you? Because you're dead or alive, and it's difficult to quibble with that. She reported in that paper that actually the absolute concentration of NT-proBNP or troponin wasn't associated with outcome. However, the rate of change was. So in the population of dogs that suffered a cardiac death, the rate of change of NT-proBNP and troponin was greater, but the rate of change of NT-proBNP was greater in earlier disease, and the rate of change of troponin was much greater in later disease. So that means that if you measure a cardiac biomarker once, even if you put them in combination with each other, they're not that useful. But if you measure them every 6 months, as Melanie did in her paper, then actually it did show that you could tease out the higher risk dogs. I guess the question that comes from that is, what do we do with that? If we are in primary care practice and we're using these cardiac biomarkers to monitor these cases, or monitor risk, I guess, in these cases, we don't know from the cardiac biomarker rate of change, which is stage B1, B2. We don't know when to intervene with the rate of change of cardiac biomarkers. So for me, I would say if we're using those biomarkers to look at rate of change and therefore stratify risk in our patients. So we say, you know what, Mrs. Jones, poor Charlie's a cavalier. Charlie, his NT-proBNP has increased and his troponin's really jumped. We're worried that he's going to die in the next 6 months. And then Mrs. Jones says, oh my goodness, so what do we do? And we go, buy a small bag of dog food. I mean, I don't know what to do with that. So I'm not saying that information is not important. And I think communicating our expectations of longevity and of quality of life are important to owners, because it's important for them to think about what's happening and be aware of what's happening and not be blindsided. But equally, if it doesn't change what we do, how useful is it? And actually, should the fact that the dog has an increase in dose of furosemide because of its heart failure be enough to make us say the prognosis is poor? I don't know. What are your thoughts? Do you use them? Do you recommend using them?
No, I do not. I do not use them, and I generally do not recommend them to primary care vets. As you were saying, I think Melanie's work is really interesting, more to assess the rate of change and so on. I think what is interesting, again, from the delay study is, because it's very cool, and again, we cannot do that in cats. It's very cool that to predict heart failure, when will they, because we see B2s, and then as you were saying, B2 has a very big range of dogs and LA size and so on. And then people have suggested in the past to try to maybe split B2 in two different groups.
We just don't need a B3, do we?
Exactly, we don't. But just to say, just to reflect that B2 is a very, very big group of cases. Yeah. And then what I think Mrs. Jones was she? Yeah, exactly. So what
Charlie Jones, yeah, an 11-year-old male neuter Cavalier King Charles Spaniel.
Exactly. So what she really wants to know is, it would be interesting to know, when does Charlie go into congestive heart failure? And to determine that, I think is very, very cool and very useful in any heart disease. So I think the risk of congestive heart failure within 6 months from the delay data show that an NT-proBNP more than 1,500, these dogs had an increased risk of congestive heart failure. So I think that's an interesting question. It's an interesting question, something that clients may ask. And so again, combining echo data and saying, okay, it's a big left atrium, more than 2.20 if you want, a big left ventricular diameter, NT-proBNP more than 1,500, the risk of congestive heart failure in the next 6 months is very high. And again, I think this is important for clients, because we all teach them to measure respiratory rate and so on. So to tell them, how worried should you be? Because if it is an early B2, you may say, you will not go into congestive heart failure probably in the next 6 months or 9 months. But then if it's a case that you clearly the risk of congestive heart failure is very, very high, and you may say, well, I don't need NT-proBNP for that. My echo variables, my echo will tell me that, and I agree. But I think that question is an interesting one from research point of view and clinic point of view. What's the risk of congestive heart failure in the next 6 months? Because I think that's a very important point for clients, for vets.
And you know, that's where rate of change of heart size comes in.
Yeah, true.
Because in all the work by Peter Lord back in the 90s, and you know, Boswood has looked at this as well. As the heart gets larger, it's the rate of change that predicts, or the rate of change in the 6 months before heart failure suddenly increases. It rapidly increases, and I think that's where rate of change of imaging variables is important. There's probably a utility of cardiac biomarkers there too, but the day-to-day variability is just so much, especially in NT-proBNP, that I don't use them, and I don't recommend people use them. I would rather people, instead of practicing how to interpret biomarkers, just practice how to measure left atrial size repeatedly. Because if you can do that, or even took a baseline radiograph when the dog's not in heart failure, miles away from heart failure, first detect a murmur, and then use your radiograph, that baseline, as your reference marker, and you monitor the radiographic change. You know, initially, if the heart's not big, you can take a picture in a year, tie it in with a routine appointment or something. And then as the heart, if you think the heart's beginning to enlarge compared to your baseline radiograph, then take it in 6 months. And you know, once they're in B2, start treatment, and then continue taking radiographs. And if one day you suddenly notice a massive jump, then you amplify your respiratory rate monitoring. You talk, maybe you give them some furosemide to put at the back of the shelf so they're ready to reach for it. So I think rate of change is very important for prognosis, and it's something that's probably most important for predicting heart failure.
Imaging, exactly, imaging. We need imaging. Yeah. X-rays, absolutely totally agree. I think we are close to the end of our podcast. Something that we did not talk about, like negative prognostic factors that are clear, is stuff like atrial fibrillation, dogs with advanced disease,
bad pulmonary hypertension.
Pulmonary hypertension, exactly. Some very nice work from Borgea there also. What I wanted to ask you is, so sometimes if we rely on LAO, in some cases, the left atrium will not dilate in an homogeneous pattern.
Right.
Describing it properly. Sometimes they have there is a huge bulge in the intraatrial septum has a huge bulge. I think I heard someone calling it like a pancake shape. I'm not sure.
My pancakes are perfectly round. I don't know what you're talking about.
Not my pancakes. But so the intraatrial septum, we see that, isn't it? That one diameter looks rather normal or mildly dilated, and they dilate in a very heterogeneous way or not homogeneous way, and they may as an example, the atrial septum is huge, or the left artery.
Sure, they're often a trapezium shape, aren't they? You know, in that long axis view. Yeah.
How do you approach those cases?
I try and find the maximum diameter where I'm not in a pulmonary vein. And that's true from the long axis as well as the short axis view. I really try to avoid the pulmonary vein. And I try and, especially in short axis, try and define my landmarks really clearly. There's that sort of bump on the left atrial wall, which is probably part of the sinus venosus valves or something that's regressed between the pulmonary vein to the sort of lateral aspect of the image and the body of the auricle. And I try and measure to that bump. And I try and, when I measure left atrial size in short axis, and I try and measure that bump very repeatedly every time. So I use an anatomic landmark rather than that whole extrapolating into the pulmonary vein thing that people do, which I think is just guesswork. Certainly in my hands, it's just guesswork. And I think in long axis, I try and get the maximum where, again, I believe I'm not in the pulmonary vein ostium. And I try to measure parallel to the mitral annulus in order to standardize my measurement. Have you got any tips?
No, I agree with you. I think these odd-shaped left atriums are a good example that we should not only rely on one measurement, and LAEO may not give you the whole picture. And so I think Visser's data, as you were saying, and measuring LA diameter in long axis would at least estimate that axis and if the intra-atrial septum is bulging a lot towards the right atrium, dilating the left atrium dilated in an odd shape, you're going to detect that enlargement. And I guess this would be again another argument to look at regurgitant fraction,
right?
Because then in those cases that will probably give you a very, very different picture.
I think if there was a reliable, repeatable way of us measuring the actual volume that's going backwards through the valve, that's bound to be the best way, because that drives everything else. The problem is we don't have that at the moment. We have some best guesses. So I think we're coming to the end of our podcast episode in the interest of time. People have finished their commute or maybe need to put the kids to bed or whatever people are doing around this podcast. It's time to summarize and think about the key messages of prognostic variables. I think stage B2 is of prognostic importance, not only, in decision-making for treatment. It does identify dogs with the worst disease. Left atrial size, left ventricular internal diameter, they are reasonable measurements to make, and they are very useful across a large number of dogs. They're accessible measurements. They are what the decision-making and the evidence base of treatment in the preclinical phase are based upon. I think if you want to go beyond that, and in some cases it's very important to go beyond that, I think level 1 is probably maximum velocity of early diastolic mitral inflow, the Emax measurement. If that's greater than 1 meters per second, 1.2, 1.4, those are much worse mitral regurgitation severities. The blood that goes backwards must come forwards, and that volume loading drives that increase in velocity. If you wanted to advance things even further, then using rate of change of those imaging variables, the heart size, to predict the onset of congestive heart failure is very useful. And I think ultimately, if you're getting very interested in echo or want to challenge yourself with your echo assessments, I think trying to estimate regurgitant fraction itself and measure the disease itself is probably the thing to do. There is a place for vena contracta in there. I think there may even be a place for jet area ratio, looking at the color Doppler. But the biggest challenges are volumetric and PISA-based methods of estimating regurgitant fraction. Give it a go, see what works for you, and find something that works in your hands that is repeatable on the same dog. And then you can use it to track change over time. Any final comments, Jose?
No, fantastic. I think you summarize it very, very well. Great. So I hope everyone enjoyed our podcast. Stay tuned and we'll be back soon.
Thanks, everybody. Don't forget to follow us on social media. Twitter and Instagram are both at heartbeat_pod. Please share with us any ideas for guests, future episode topics, or any questions that you might have along the way. Thanks very much.
Have a great day.